Dr. Forte established a multidisciplinary research team studying the neurovascular complications of sickle cell disease and associated biomarkers. Dr. Forte is here today to just give us an update on hydroxyurea and Adakveo. I know in the program it has the proper terminology, but it's early for Alvin right now, so we're just going to go with Adakveo.
Okay.
Dr. Forte?
See my slides here? Okay, good. Alors, bienvenue à Montréal. Hello, everyone, welcome to Montreal. Let's see if I can get the slides to work. Okay, excellent. So I'm going to do a brief update on hydroxyurea and crizanlizumab. So first, here are my disclosures. So I must declare that I'm going to discuss off-label use of hydroxyurea. And this is kind of an absurd situation, but sickle cell disease is not listed as an indication for hydroxyurea by Health Canada. So this creates very unfortunate situations where, for example, children don't have access to hydroxyurea in Alberta, and this adds to the barriers, and we'll be discussing some of that today. So despite being an off-label use, I prescribe a lot of hydroxyurea. There's very convincing evidence that it's the cornerstone of treatment of sickle cell disease, and it's a safe medication, and it works for many patients. I'm also going to discuss the recent crizanlizumab trials, and we're going to reflect a bit on the successes and failures of these trials. So as you are all aware, sickle cell disease is a global issue. It's the most common genetic disorder worldwide. So as we discuss these inequities, of course, there's also a more global scale where we realize that there are some parts in the world where most patients with sickle cell live, where they don't even have access to hydroxyurea, or where a simple CBC could just rob a family of a week's income. And this is not only very unfortunate on a human level, but even on a scientific level, I find it quite shocking that sickle cell disease, which was the first molecular disease, there was really a Nobel Prize that was handed to Dr. Pulling and his team for the discovery of this molecular disease, and still there was very limited scientific development until recently. And the discovery of this genetic disease has really launched modern medicine. And many of our cancer treatments and other treatments in sickle cell, for example, in cystic fibrosis or hemophilia, have benefited from this early research. So, as we all know, sickle cell disease should actually be more termed sickle cell diseases. There are many forms. Every patient is different. We know also about the different genotypes that exist that are all caused by mutations in the beta globin genes, that there are different types. And most research and most clinical studies have focused on the SSS and S-beta-0 patients because they are considered more severe, which means that some of the drugs have not been fully tested in SC patients or S-beta plus patients, but we're discovering now that they can actually have quite an impact on the quality of life, and they should definitely be an effort made to include these patients in all trials. So this slide is quite familiar to most of you. This is kind of the pathophysiology of sickle cell disease. We know now it's not only that sickled red blood cells go and obstruct the blood flow. In some patients, depending on each patient is a bit different, but there's probably a mix of things happening at the same time in a given patient. So for example, in patients with more severe pain crises, it's hypothesized that actually they might have more sticky white blood cells, more platelets sticking, more red blood sticking, and all of this contributes to the pain. And then maybe patients who have more of the pulmonary hypertension and stroke may have more of the hemolysis when the red blood cells break down and substances get released that cause inflammation and make the endothelium sick. So all of that being said, we know about these multiple complications, the acute complications, But now that patients are aging, we discover also the more chronic complications. So one way of seeing it is that sickle cell disease is actually accelerated aging. So some of the heart failure or kidney failure that can be seen in aging adults, we see it much earlier in sickle cell disease. So we need therapies that not only prevent the acute events, but that can also protect the organs from early organ damage. And I mean, you're all familiar with this, but often when we treat patients with sickle cell disease, we're considered benign hematologists, but we're trying to kind of get rid of that term because there's nothing benign about sickle cell disease. And this slide shows that quality of life in patients with sickle cell disease is similar to patients who are on chemotherapy for cancer. The only difference is that sickle cell disease, you have it from the day you were born to the day you die. So some of the reflections about what would be a good treatment for sickle cell disease. So now there's a new dawn, so many would say the ideal treatment is a cure. But it's not available to all yet, and it maybe take some time before it really gets optimized and available to many people. So right now, what would be appropriate? So it's something that would be probably like an oral medication that's easy to take, not too expensive, has known efficacy on blood parameters, clinical relevant outcomes, and has a sustained effect over time with minimal side effects. So I believe hydroxyurea has several of these features, and what is interesting about this medication is it works on different mechanisms of the sickle cell disease. So one of the main mechanisms is that it increases fetal hemoglobin, but it also acts on the stickiness of the blood cells. It can reduce the amount of lysis, so the destruction of the red blood cells, and increase the availability of nitric oxide so that blood vessels can relax and the blood can flow more easily. So this is an illustration of a patient taking hydroxyurea, and you can see that with the fetal hemoglobin induction, they have less of the sickle cells on the film, and this is from the patient leaflet on hydroxyurea from Camille. So what about safety? Well, we have more than 50 years of data now on sickle cell disease. There have been well-conducted trials, and it's safe in children as young as 9 months of age. And more recently, we had excellent trials that were done in sub-Saharan Africa that showed that it can be safely delivered even in lower resource countries where there's a lot of malaria and infections. And actually there was signal also that it was actually protective against severe infections and deaths. So this is very reassuring data, and it's another argument why hydroxyurea should really be made available all around the globe. So I'm going to go a bit faster because there's so much I want to say about this topic. I can talk about it all day long, but I want to hear everyone else as well. So hydroxyurea, there was a key study in the 90s where patients were randomized to either receiving hydroxyurea or placebo. So placebo, really a drug looking the same as the medication, but without the active ingredient. And the dose was pushed to maximum tolerated dose. So patients had follow-up with blood tests until the right dose was reached for the patient. And this had a striking effect on the number of hospitalizations, which were reduced by about 45%, 50%, less pain crises, less acute chest syndrome, and less transfusions. So convincing evidence, absolutely. And then now, with the follow-up of 17 years, we can see that not only had these patients less acute events, they also lived longer, the ones who were assigned to hydroxyurea. And we also have data from Greece and Brazil that patients who are on hydroxyurea have longer survival. When they looked at the causes of deaths in those on hydroxyurea and not on hydroxyurea, this was quite interesting. Less patients on hydroxyurea died of stroke, kidney disease, liver disease. So these are other arguments that tell us that hydroxyurea is not only good to prevent the acute events, but it's probably an essential medication as well to prevent the long-term organ damage. And the longer you take it, the higher the effect. So you don't get used to this medication. It's not something that needs to be changed at some point because it's losing its effect. It's a long-term effect. So is it safe? Well, we know about the dose-related side effects. The most common are the lower blood counts, so that's why the medication is adjusted for each patient individually based on CDC. There can be a bit of nausea when we start the medication and nail discoloration. But for sure, you will see a lot of information out there, and this is kind of unfortunate. It is because it was initially prescribed as a chemotherapy. So some of these side effects don't really apply to the situation of sickle cell disease. And there was really nice work done by Dr. Forte and her team, where they actually collected patient information handouts from almost all pharmacies of Ontario, and all contained inaccurate statements about hydroxyurea. So this is really contributing to misinformation, and it's an additional barriers to uptake of hydroxyurea for our patients. It's actually quite worrisome what you could read in there. For example, hydroxyurea can lead to very bad and sometimes deadly bleeding complications or infections. One of my patients was told she could not touch her children, she should put gloves on because it's chemotherapy. One of my patients was told that she needed to provide a blood pregnancy test every month to the pharmacist, otherwise he would not serve the medication. So this shows that we have education to do. And not just in Ontario, I think we have the same issue all across Canada. So what can we do? One of the strategies is to use the excellent Canadian patient handouts about hydroxyurea. They exist in French, in English, for the parents, for the adults. Very readable and clear information. What's interesting about that is, for example, at Saint-Justine, the children's hospital, the first time hydroxyurea gets provided for a family, it's actually provided by the hospital. So the hospital pharmacist can provide accurate information, and it's very reassuring for the family because before they go out into the community. So that being said, who should take hydroxyurea? Well, I think it's something that should be discussed with every patient, every family. For me, it's a bit like, let's put a seatbelt on. Should we really wait for an acute complication to happen and then put the seatbelt on, or should we start it right away? And it's a general approach for SS and S-beta-0 patients to really offer this to the families and the children early on. For SC patients and S-beta plus patients, we don't really know. We don't have much data. But from clinical experience, I can tell you that some of my patients, it really helped them. So it's something that we can discuss on a case-by-case basis. I'm going to skip this, but we can keep this for questions. So there are many barriers to appropriate therapy. Of course, for some patients, it's a big decision to start taking the medication every day of their life. And that's something that we often discuss. But I think it's more interesting at this point to focus also at the provider level and the system level and initiatives of what Dr. Forte is leading, like what can we do to make these medications really more accessible to everyone. So this of course also needs a lot of involvement from multidisciplinary care teams. So we really depend on our nurses and social workers to identify some of these barriers. During the pandemic and then the inflation, some of our patients had to stop taking the medication because it was just too expensive. And we had a Sickle Cell Disease Association of Quebec who stepped in and provided emergency support, but for some patients, the $100 a month was just too much. and they could not afford the medication, which again is kind of an absurd situation that we're in. So in summary, I think hydroxyurea is a good drug. In most situations, I think there is some benefit of trying it. But at this point, we really have a one-size-fits-all strategy for the patients. And for some patients, it's just not the right fit. It doesn't work, it's not enough. They can have side effects or barriers that make it for them not possible. So we have to look at alternatives. And this is where it's encouraging to see that there are several clinical trials recently that tested novel drugs in sickle cell disease. One that was talked about much is crizanlizumab, and I'm going to briefly explain what the theory is, how it's supposed to work. So as we were saying, there's a lot of stickiness going on in the small blood vessels, and some of it is mediated by P-selectin. And the crizanlizumab targets that P-selectin so that the white blood cells, the red blood cells, the platelets don't stick as much. The idea is to make the blood flow more easily. Now, how is this medication given? So it's an intravenous administration over 30 minutes. So it has to be given in a hospital or in like a special medical setting. The first doses are given 2 weeks apart, and there's an observation period where the patient has to sit for up to an hour just to see if there's a reaction to the drug. And then it's given every 4 weeks. And it can be given with hydroxyurea or without. And at this point, there's very limited access in Canada, and we'll see some of the reasons. So the first major trial that tested this medication is the SUSTAIN trial from 2017. So this is an American trial. It's considered a phase 2 trial because there were not enough patients and they were not followed long enough to really have like a very firm conclusion of whether it works or not. So it's it was considered mostly preliminary and establishing safety. And we can see there were 3 groups of patients. Some were on placebo, some were on low dose crizanlizumab, and some on high dose. And in red, you see the patients on the high dose, and they had less pain events. Okay, so this was quite interesting with a 45% reduction in pain crises, with side effects that were mostly joint pain, headaches, nausea, back pain, a bit of fever. And more long-term data showed that there were also less hospitalizations in those on the high dose crizanlizumab. So is this drug accessible? Well, in the USA, it became accessible in 2019 when the FDA granted approval. In the European Union, it became available in 2020, but it was conditional on conducting a larger trial with longer follow-up to establish the efficacy and long-term safety. And then, as we will see, there was a follow-up trial that was quite disappointing, and the European Union withdrew the authorization in the summer of 2023. The UK granted conditional approval, and in Canada, I'm not aware that anything was filed to Health Canada for approval. So once these different organizations approved it, there was a lot of media coverage. Some of it actually was over-optimistic. Here we have one quote, for example, that this revolutionary treatment will help save lives and better quality of life, but with the data I just showed you, the study did not evaluate that. So it is a bit unfortunate because it gave sickle cell disease media coverage, but it did not provide accurate information. And people may actually think, oh, that's it. We found a solution for sickle cell disease. So there was some issues with the media coverage, and there was a very nice article in the UK where they looked at 29 articles that came out. 11% stated unproven benefits of the drug and only 14% had satisfactory quality. So this is what the general public hears about sickle cell disease, and its treatment, and it's not accurate. So then, of course, it was a big disappointment after all this hype when the STAND trial provided preliminary results. So this was a larger trial with 2 doses of crizanlizumab against placebo. And I'm going to go straight to the conclusions because in January, the company Novartis provided an update saying that there was no statistical significant difference in pain crises, and actually that the EMA was reevaluating the approval of the medication. So huge disappointment. And let's think a bit, what can explain these discrepancies? So one of the reasons is probably because the definition of pain crisis was not the same in the trials. The initial trial was any pain crisis that resulted in a medical facility visit, whereas the most recent trial, it was a contact with a healthcare provider, so it could be even home management of sickle pain. And that makes sense because when we talk to our patients who are on the special access program with crizanlizumab, some of them tell us, I still get pain crises, but they don't bring me to the ER, which for them is actually quite an improvement. But this is only like personal empirical data. Let's see how this rolls out. The other thing is maybe we did not have to, these were not exactly the same patients, and maybe there's a subgroup of patients where this drug really has clinical benefit, and maybe it's not, again, a one-size-fits-all that can be applied to all patients. So here are some hypotheses. This is completely preliminary data from a recent conference in Europe. So again, to be taken with a grain of salt, but that can maybe help us understand why there was this discrepancy. So in children, the Solid Kids phase 2 trial was in children. They looked at children 12 to 18. They looked at crizanlizumab and how the number of how many pain crises they had compared to baseline. And if we look at the children who were not on hydroxyurea, there was a significant reduction in pain crises. That's to the left. And completely to the right, it's the patients who had more than 5 pain crises a year. These seem to have the most benefit also of crizanlizumab. But again, they were just compared to themselves. So maybe it's just the fact that they were in a trial with more monitoring that made their disease look more severe. But it's a hypothesis why we see this discrepancy. So I'm going to go to my conclusions now, to be mindful of time. So it is really an absurd situation that at this point there's no drug specifically approved for sickle cell disease in Canada. This contributes to disinformation, as we saw with the study with community pharmacists. It's also a problem for clinical trial design because when you're comparing a new drug, you cannot compare it to hydroxyurea. It's a very complicated situation. The other thing is that we really need additional therapies, and we need to get the patients involved in the trial design. But as we saw with other medications, our patients actively participate in the trial, but when it comes to time to actually file to Health Canada to get this drug approved, the market in Canada is considered too small, so it's not worth the trouble. So maybe this is an oversimplification of what's really going on, I'm not aware. But I think we really need to ask for a commitment of the pharmaceutical companies we're working with, because our patients are really active participants in the trials, and patients deserve to get access to these drugs. So this also highlights the importance of education and the kinds of events we're having today. I'm sorry if I went a little bit over time, and I hope we have a bit of time for questions. Thank you.
Thank you, Dr. Forte. Due to the fact that it is a little over, I'm going to limit the question period to only 5 minutes. So if anybody has questions, please feel free to again approach the mics that are on either side of the room. And again, I will have to limit this to about 5 minutes, so bear with us. And by the way, this is the cutest blood cell I've ever seen before in my life.
Yeah, you know what? I made that for the director of my hospital so that he always remembers benign hematology.
So you needed this? You needed this yourself?
Yeah, it's an anti-stress,
I see dollar signs.
Being the evidence that you have logged into the health electronic records to Health Canada, because it seems you have a lot of real-world data already, and there has been some study in the US, and I think FDA is now accepting real-world record from electronic health records as evidence in cases where you do not have enough sufficient clinical data available. So I was wondering, is there any initiative in terms of mining the real-world data that you have as evidence to Health Canada, perhaps using machine learning, which is already been done in other diseases like cancer, for example? So that's the question.
That's a wonderful idea. I'm thinking about that to see, well, there are a lot of barriers of just using the medical record. We use different system in almost every hospital, but let's be positive. Let's see, for example, for crizanlizumab, when we get it through the special access program, we need to participate in kind of like a registry that has very minimal data, but at least we know where the patients are and if it's beneficial for them. So there's a bit of data being collected there by the company. But I'm not aware of a Canadian initiative, but I think it would be interesting also to see like the impact on survival. Do patients have access to hydroxyurea across Canada? And what about novel medications? Yeah, thank you.
Merci beaucoup pour votre présentation, Dr. Forte. Je vais poser ma question en français parce que je ne veux pas manquer des éléments. Puis après, vous pouvez répondre en anglais, il n'y a pas de problème. Moi, je fais partie des premières patients qui ont été suivis à Sainte-Justine avec Dr. Yo en 1982-84. J'ai commencé à prendre l'hydroxyurée 90-92. Alors, ça fait longtemps que je suis là-dessus. Malheureusement, il manque beaucoup encore de données quant à l'effet en gynécologie, parce que j'ai eu beaucoup de problèmes au niveau des menstruations et tout ça, mais il n'y a aucun médecin qui semble prendre ce sujet-là au sérieux. Donc, nous sommes des femmes, la reproduction, mais j'ai eu beaucoup de difficultés, puis c'est très tard, vers début de la quarantaine, que là j'ai appris que j'étais infertile. Ça a été un coup de choc parce que ça faisait depuis le secondaire que je disais j'ai beaucoup de problèmes, mais je n'étais pas capable de me dire ça doit être la nuit, ça doit être la nuit, ça doit être la nuit, mais il n'y avait pas de données. Alors j'aimerais savoir l'impact vraiment, est-ce qu'on pousse la recherche sur l'hydroxyurée pour savoir l'impact exactement sur le corps des femmes là, qui souffrent de la maladie d'anémie falciforme. Parce que jusqu'à présent, personne n'est capable de me dire c'est dû à quoi ce que j'ai vécu jusqu'à ce jour là, par rapport à cette donnée spécifique-là. C'est ce que j'aimerais savoir.
Yeah, so I understand you have been taking hydroxyurea for a very long time. You're one of the first patients in Quebec, and you started it as a kid with Dr. Hume. And then over your lifetime, you had issues with menstrual cycles and fertility, and you're wondering if it's connected to hydroxyurea. You're still looking for answers. Yeah, so I think it's a very important question. There are registries of women who were taking hydroxyurea and even during their pregnancy, and they have healthy babies. But I think there's only one group I know of in the US who's now looking more proactively, for example, at hormones in women who are taking hydroxyurea to try to understand. Because there's lots of things going on when the disease is out of control, where you have an active disease. It can also cause menstrual problems and infertility. So what is exactly going on. I think, yeah, we need more research, and we need endocrinologists and gynecologists who are interested in learning about this with us, who really get involved, because it's an important topic. I agree.
Thank you so much, Dr. Forte.